Okay.
Yeah, you're coming up now. Yeah, outline.
All right, ma. Okay, ma. Can you see, ma?
Very
Hello,
well,
ma.
thank you. Yes, I can see it
All right,
very
ma.
well. At
Thank you,
7
ma.
minutes, start now.
Yes, ma. Good morning, the chairman, panelists, and all participants. I'm Dr. Ogun Kwadi, and I'll be presenting obstetrics outcome of patients with hemoglobinopathies at the University College Hospital, Ibadan, over a period of 10 years. I'll be making use of the following outline. Pregnancy in sickle cell disease, excuse me. Pregnancy in sickle cell disease patients is associated with increased risk of maternal and fetal morbidity and mortality. However, it's been noticed that with improvement in management, patients now present better with quality of life into adulthood, with an upward increase in their presentation for obstetric purposes, hence the need for this research. And it was aimed to determine the obstetric outcome of patients with hemoglobinopathies and in the University College Hospital, Ibadan, Nigeria, over a period of 10 years. It was a retrospective study of the obstetrics and gynecology department between January 1, 2008 and December 31, 2017. Data were extracted from the folders, and these were entered into a pro forma. Relevant records, including the demographical status of the patients, the complications of the disease and pregnancy, and during the antenatal period, labor and puerperium, and at delivery and the fetal outcomes were retrieved, and these were analyzed using statistical package for social sciences. A total of 127 patients were managed during this period, and out of which 106 case files were available for analysis. 60.4% of the patients had sickle cell anemia, while only 3 of them had the hemoglobin C variants. And the maternal age, average maternal age was 29.5 years, with majority of them having tertiary education. The average age at gestational age at booking was 19.4 weeks. The commonest antenatal complication was anemia, with about 57.5% of them requiring blood transfusion. The mean gestational age at delivery was 33.5 weeks, and we had 85% live births with an average birth weight of 2.3 kilograms. We recorded 3 maternal deaths and 15% perinatal mortality. This is a table showing the demographical status of the patients. Majority of the patients were employed, and many of them had tertiary education. This is another table showing the variants of the hemoglobinopathies that we had, with the sickle cell anemia, hemoglobin S having the highest variant, and majority of the patients seen within this period were booked patients. This is a bar chart showing the mode of delivery. The highest mode of delivery was spontaneous vaginal delivery, taking 41.5%. This is another bar chart showing the various complications that were recorded, with anemia having the highest complications recorded throughout the prenatal, natal, and the postnatal period. And here is a pie chart showing the discharge status. We had majority of the patients coming out satisfactorily, having satisfactory discharge status. Discussing this in summary, we had a total of 106 patients seen within the period of this 10 years. It was a sizable number as compared to previous studies in Ibadan and Enugu, in which they had less than 50 patients within the period of study. The mean age of the patient was 29.5 years, with greater number of them having tertiary education. And this could have added to the health-seeking behavior of the study group. However, majority booked late, with 49% of them booking in the 3rd trimester. And this may have accounted for the rate of antenatal admissions and the significant anemia that was recorded as a major perinatal complication. It was similar in previous studies at Ibadan, Jos, Lagos, and Enugu. Greater percentage of the patients had spontaneous vaginal delivery with satisfactory maternal and fetal outcome. there was a high abdominal delivery and instrumental vaginal delivery. This was similar to previous studies in patients with sickle cell disease in pregnancy at Jos, Enugu, and Lagos. Most of the unbooked patients were referred from primary healthcare facilities. They were either referred in labor or at near term with perinatal complications such as anemia, bone and bone pain crisis. This was an indication of the level of our health system and inadequate referral system, which is still very poor. There were 3 maternal deaths, out of which 2 were unbooked, and deaths occurred within 2 days of delivery. In conclusion, although this study may be insufficient to make a general conclusion because of its retrospective nature, it is still pertinent and consistent with previous findings that pregnancy with sickle cell disease is associated with high maternal and fetal morbidity and mortality. However, with improvement in nutrition, preconception care, early booking, more strides will still be attained. And so we recommended that efforts should still be geared towards public education and awareness, because many people are still not aware of the problems of this disease and that it still occurs. And then there is need for training and retraining of health workers, especially at the primary health levels, so that they know when to refer and when not to even manage a patient at all. More emphasis has to be put on preconception care, early booking, close monitoring in the antenatal, labor, and puerperium. Thank you. These are the selected references. Thank you, sirs and mass.
Thank you very much, Ogunko Ade, for keeping to time. We'll take the questions at the end of the presentations. So just put them in the chat or question and answer section. Can we move on to Dr. Thank you. Dr. Adeoti, a 5-year retrospective review of singleton breech deliveries at Adeoyo Maternity Hospital, Ibadan. Dr. Adeoti, are you there? Dr. Adeoti?
I don't see Dr. Adeoti, so maybe we should take the next presenter and then we'll come back if Dr. Adeoti is able to join us.
Okay, so let's take Dr. Olukumi, Dr. Obilade Olukumi, outcome of cesarean delivery in Adeoyo Maternity Teaching Hospital, Ibadan. Is Olukumi there?
Good morning, Mars and Sars. Yeah. Women, my teachers and senior colleagues. I'm Dr. Obilade Adekunle from Adeoyo Maternity Teaching Hospital. I'll be presenting outcome of cesarean delivery in Adeoyo Maternity Teaching Hospital. Sorry, I'm trying to. So I'll be presenting outcome of cesarean delivery in Adeoyo Maternity Teaching Hospital, Ibadan. I will follow these outlines. As we all know, cesarean delivery is delivery of the fetus, placenta, and membrane after the viability through an incision made on the abdomen as well as on the uterus. It is the second commonest surgical procedure in obstetrics after episiotomy, and the general incidence of the general cesarean section rate is between 5 and 25%, and this figure continues to rise. It is being performed all over the world with an increasing rate because of improved method of infection control, anesthesia, blood banking system, and also there's a wide list of indication, improved inpatient education, which leads to better acceptance of the procedure, especially in this in developing countries like Nigeria. Then there's also increased safety of the procedure achieved by the maternal and fetal outcome. Also for fear of litigation among obstetricians. Despite improvement in safety of cesarean section in modern obstetrics, cesarean sections still carry higher risk when compared, both for the mother and the fetal when compared with a spontaneous vaginal delivery. There is positive data on outcome of cesarean section in this center, and that's the reason for this study. The objective is to determine the cesarean section rates and describe the complications associated with cesarean section in Adeoyo Maternity Teaching Hospital, Ibadan. It was a retrospective study carried out between January 2012 to December 2016. Relevant data were extracted from case files of patients who had cesarean section within the year of review from record in labor ward and operating theater. The data were entered into statistical package for social science students for 22 for analysis. The results were expressed in frequencies, percentage, means, tables, figures, and charts. Ethical approval was obtained from the Hospital Ethical Committee. There were 17,339 total delivery and 1,369 sections. 945 case files were available for analysis. That gives case note rate of 72%. The success rate from this study was found to be 7.5%. Emergency and elective was 34.9%. This chart shows age distribution. Most of the patients age ranges between 26 and 35 years, and they are majorly nulliparous and primipara. They are also majorly traders, civil servants, and artisans. The leading indication for cesarean section from this study was previous cesarean section, which constitutes 26.1%. This was followed by cephalopevic disproportion stroke obstructed labor, malpresentation, pregnancy-induced hypertension, fetal distress, antepartum hemorrhage, maternal requests, previous mammotomy, and others. Repeat cesarean section was still the leading indication among the book patients, that constitutes 28%, while cephalopevic disproportion and the obstructed labor was the leading indication among unbooked patients. This chart shows some of the outcomes. The minimum blood loss from this study was 100 mils, while the maximum was 2,000 mils, and average blood loss at surgery was 465 mils. And then average gestational age, minimum gestational age at booking was 6 weeks, and maximum was 40 weeks. Average gestational age at booking was 23.9 weeks. The birth weight, minimum birth weight from this study was 1.0, maximum was 6.8. There were maternal complications in 16.8%, and fetal complication is 18.7%. And the leading maternal complication was primary postpartum hemorrhage, which constitutes 11.7%. This was followed by sepsis, 1.7%, maternal death in 4 patients, which constitutes 0.4%, prolonged hospital stay of 0.4%, and bladder injury, 0.2%, bowel injury, 0.1%. The leading fetal complication was mild to moderate but asphyxia, which constitutes 3.3%. This was followed by neonatal sepsis, 3.0%, stillbirth, 2.5%, neonatal jaundice, 1.0%, and other. I want to make mention of severe birth asphyxia, which constitutes 1.2%, and the meconium aspiration syndrome, about 0.8%. There were 4 maternal deaths. This gives maternal mortality ratio of 434 per 100,000 live births in this study for this cesarean section. And also there were 2.5% stillbirth and 1.3 early neonatal death. And that gives prenatal mortality rate of 38.1 per 1,000 births. This table shows a fetal maternal outcome cross-tabulated against booking status. The commonest, the maternal complication was more common among the unbooked patients. Likewise, fetal complication was more common among the unbooked patients. Cesarean section rates found in this study was 7.5%. This was higher than previous reported study in Calabar, which was 5.39, and lower than the 9.0 reported, 9.9 reported from Sokoto, 10.3% from Enugu, 20.3 from Benin Kebbi, and 22% from University College Hospital Ibadan, which is around the same location at the maternity hospital. However, it was within the range of 6.4 to 32.2, which was general range in Nigeria, and also fall within the WHO acceptable limit of 15%. Similar to earlier study from other parts of the country, majority of the cesarean were emergencies, despite the majority of patients being booked, because large number of the patients, large number of the 14 previous cesarean who present in labor. The most common indication in this study, repeat cesarean, has also been found in previous studies. Repeat cesarean was still the leading cause among was it the most common indication among the book patient? Why pelvic disproportion and obstructed labor were the most common cause among the book patient? Repeat section was undertaken in many patients with one previous section when there is a recurrent indication such as pelvic disproportion, and in patients with two previous section. Previous section was said to constitute the highest single indication for repeat section because of the section regard vaginal birth after section as a high-risk option. Section was performed for obstetric reason majorly, as maternal request was found to be 0.3%. Maternal complication rate in this study was 16.8%, which was higher than the 30.3 reported from Sokoto, but lower compared to a previous study from Sokoto, which quoted 20.4%, and then also lower than 39.3 reported from Maiduguri. Maternal complication rate was higher among the book cases compared to book cases, 28% versus 13% respectively, because most of the book patients presented in an emergency situation with already compromised health status. The prenatal mortality rate in this study was 38.
Can you just begin to round up?
Okay, so in conclusion, there are more emergency surgery than elective, and on book patient had more complications. So good antenatal care and improvement in skills and management of PPH during and after session will help to reduce complication. Thank you, sir. These are my references.
Thank you, Dr. Adekunle. We'll take the questions end of the presentation.
Okay,
Can we move on to Dr. Abo Briggs? Dr. Abo Briggs, Taminosaki, early pregnancy maternal neck circumference as a screening tool for gestational diabetes in a tertiary hospital in Ibadan. Thank you. Dr. Abo Briggs.
Good morning, ma.
Good morning. You have 7 minutes. Let's skip to time.
Okay. Is my screen visible, please?
Yes, it is.
Okay. Thank you very much. Good morning. Permit me to stand on existing protocols. My name is Abo Briggs Taminosaki Wilfred, and I'll be speaking on early pregnancy maternal neck circumference as a screening tool for gestational diabetes mellitus in a tertiary hospital in Ibadan. My co-authors are Drs. Additional and Moasim Bello. I'll be following this outline as projected above. Gestational diabetes mellitus is a common pregnancy complication, a public health problem, and a threat to maternal and child health. Traditionally, it has been defined as any degree of glucose intolerance or variable severity.
We have a challenge with this audio, please. Hello?
Yes, we've lost Dr. Gunkwade. I mean,
Dr. Abo Briggs.
Abo Briggs, sorry. Abo Briggs.
Set of first recognitive controversies, universal screening. Hello?
Okay.
Hello.
Okay. Yeah, we can hear you now.
Yeah.
Okay. Universal screening for gestational diabetes mellitus with the oral glucose tolerance test is advocated globally. This might seem perfect in developed countries, but may be a challenge in developing resource-poor countries who usually have a large obstetric population and might not have facilities to carry out the oral glucose tolerance test. Maternal neck circumference, which is an index of upper fat distribution, is a novel, readily accessible, cheap, and easy to measure anthropometric screening tool that varies less with pregnancy. And it has been validated to predict cardiometabolic disorders like type 2 diabetes mellitus and metabolic syndrome in the non-pregnant population. And more recently, it has been used to validate gestational diabetes mellitus. Hence, the question will be why the study. Published data have been limited and to the Asian continent with varying neck circumference values. And due to the differences in body habitus, ethnic and racial differences, it may be difficult to extrapolate these values to African pregnant women. And as it is, there are no published data on this amongst our pregnant women. So our objective was to determine if maternal neck circumference measured between 14 to 20 weeks of pregnancy was associated, could predict the risk of developing gestational diabetes mellitus, and to determine a predictive cutoff value among pregnant women attending the antenatal clinic of the University College Hospital, Ibadan. This was a prospective longitudinal study of 262 pregnant women aged between 18 to 45 years who were recruited at the booking clinic of the University College Hospital, Ibadan from May 2019 to April 2020 after informed consent was taken. Pregnancy was confirmed with a first trimester scan, and by exclusion criteria were patients, pregnant women who are less than 18 years, those with multiple gestation, thyroid disease, neck swelling, or surgery, who are on steroids, and who had pre-existing diabetes mellitus or any endocrine disorders. And data from all the study participants were collected at 2 time points, at 14 to 20 weeks, and then 24 to 28 weeks of pregnancy. At first contact, the demographic, anthropometric, and obstetric data were obtained. And the second contact, all participants had a 2 hours and 5 grams oral glucose tolerance test after an overnight fast of at least 8 hours. And gestational diabetes mellitus was diagnosed using the International Association of the Diabetes and Pregnancy Study Group criteria. Participants diagnosed with gestational diabetes mellitus at 24 to 28 weeks of gestation were assigned to 2 groups, the GDM group, those that were diagnosed GDM, and those that had normal values were assigned the normal group. In French, descriptive statistics were used to present the baseline characteristics, and the receiver operating characteristic curve were generated and used to determine an optimal cutoff value by plotting the sensitivity over 1 minus specificity, and then we calculated the area under the curve to assess the diagnostic efficiency of neck circumference. And then the logistic regression analysis were used to determine the predictability of neck circumference and determine the risk of gestational diabetes mellitus. So of the 262 participants, 248 completed the study, having a dropout rate of 14. The mean age for the study participants were 31.65 years. The mean neck circumference was 34.56 centimeters, and the mean gestational age was 17.8 weeks. Gestational diabetes mellitus was diagnosed in 49 of the 248 women, giving an incidence rate from our study and in our center to be 19.8%. Now, looking at this table shows the baseline obstetric and anthropometric characteristics, and summarily shows that the mean weight, the body mass index, and then the mean neck circumference, blood pressure, and OGTT results were statistically or significantly higher in the GDM group as compared to the normal group. Also, testing the association between neck circumference and gestational diabetes mellitus, we found a positive association between these 2 variables, and this was statistically significant, as depicted by the p-value. When we plotted the receiver operative characteristic curve, we determined an optimal neck circumference for our environment to be 34.50 centimeters with a sensitivity of 69% and a relatively low specificity of 42%. And when we analyzed the area under the curve, we got a value of about 67%, meaning that neck circumference performed pretty well as a screening tool based on its relatively high sensitivity and had a relatively strong predictive value based on the area under the curve. And then when we did the logistic regression analysis and we adjusted for age and other confounding factors, we found out that maternal neck circumference was an independent risk factor, a predictor rather, for gestational diabetes mellitus. And then comparing this with other available published data on the same issue.
Can you move on? You're running out of time.
Okay, so we found out that our value, our cutoff value was comparable to other studies except for Cellularity, which was their own cutoff value was relatively higher, but our AOC and predictive value was strongest amongst the other published data. So in conclusion, early pregnancy maternal neck circumference was associated with and is a valid, reliable, cheap, and readily accessible screening tool for gestational diabetes mellitus, low resource settings. And we got a predictive neck circumference cutoff value of 34.5 cm. And so we recommend that where appropriate or indicated, maternal neck circumference, either alone or in combination with other screening tools, may be used in early pregnancy as a screening tool for GDM, especially in resource-poor rural hospitals that lack personnel or equipment to perform the oral glucose tolerance test. And future research with a larger sample size and multi-center participation would make our findings more valid and generalizable. Thank you very much. These are my selected references.
Thank you, Dr. Bobricks. We'll move on to the next presentation, which is by Dr. Ajoku, Prevalence of Anemia in Pregnancy at Booking in the University of Calabar Teaching Hospital, Calabar, Nigeria. Dr. Ajoku, are you around?
Yeah, I am.
Okay, can you share
Good
your
morning.
slides, please? Only you have
All right,
7 minutes. Please, let's keep to time.
Yes, ma'am.
You can't see your slides yet.
Can you share or should I share?
can. I'm trying to start it up. Can you see the slide?
Yes, we can.
Okay.
Good, you have 7 minutes.
All right. Good morning, my distinguished participants. My name is Dr. Vivian Ajoku. I'm a senior registrar in the Department of Obstetrics and Gynecology in University of Calabar Teaching Hospital. The title of our paper is The Prevalence of Anemia in Pregnant Women at Booking in the University of Calabar Teaching Hospital, Cross River State, Nigeria. And my co-authors are Professor Etuk and Dr. Omoria. I'll take it under the following outline. And by way of introduction, I want to say that anemia is a global health problem that affects both developing and developed countries. It has been estimated to affect 1.6 billion people, and of these, 56 million are pregnant women. The World Health Organization has put the prevalence in developing countries to vary between 53.8 and 90%, and in developed countries to vary between 8.3 and 23%. According to WHO, anemia in pregnancy is defined as spark cell volume of less than 33% in pregnant women. It is responsible for 20% of maternal death in Africa and about 11% of maternal death in Nigeria. It has also been shown to be a significant cause of perinatal morbidity and mortality, with the greatest burden borne by Asia and Africa. It has been classified into mild, moderate, and severe, as is shown on the screen. The other deleterious effects of anemia in pregnancy include increased predisposition to having miscarriages, preterm delivery, and low birth weight babies. It impacts negatively on the intelligence of the child, the development, and the behavior of the child. As we all know that an anemic pregnant woman succumbs easily to obstetric hemorrhage and puerperal infection. So the objectives of our study was to determine the prevalence of anemia in pregnant women at Booking in the University of Calabar Teaching Hospital, and also to determine the social demographic and other factors that can be associated with anemia amongst pregnant women at their first antenatal visit. The study was conducted in our facility from the month of March to July 2019, and approval for the research was given by the Research Ethics Committee of the hospital, and all the pregnant women who came for their first antenatal visit, who fulfilled inclusion criteria and gave consent for the study, were recruited. It was a prospective cross-sectional study that was conducted using a semi-structured interviewer-administered questionnaire, which was used to obtain information from the consenting pregnant women. And the results were analyzed using inferential statistics, using tables, frequency, and percentages. We calculated the sample size using the general formula for the single population proportions, and we had a sample size of 441. And amongst these, 237 subjects were found to be anemic. That gave us a prevalence of 53.7%, which is not far-fetched from the WHO prevalence of anemia in the developing countries, which I said earlier, that vary between 8 and 90%. Majority of the candidates of the subjects had mild anemia, while the rest had moderate anemia. There was no severe form of anemia. This is a pie chart that is showing the distribution of study participants based on the severity of anemia. And you can see here that majority of the subjects had mild anemia, which is represented in blue, and 20% had moderate anemia. Now, this is a table that is showing the relationship between social demographic characteristics and anemia at booking. And from what we can see, that the age and the marital status did not really affect the prevalence of anemia on this table. However, the educational status affected the prevalence of anemia. Looking at the table, you can see that those who did not have any formal level of education were more predisposed to having anemia. And the prevalence of anemia reduced with increasing level of education. Now, this the p-value is put at 0.04, and that can be explained by the we've always known that knowledge is power. So that can be explained that by the fact that these women are more have more knowledge at their disposal compared to those who did not have any formal level of education. And there was a similar finding in some other studies that were carried out in the South-South and also in the Southeast. The level of income also played a major role, as we can see from the table that those who had a salary income of 100,000 and less were more predisposed to having anemia from the table. And a similar finding was also seen in India, a study that was conducted in India. From this table, this is a table showing relationship between obstetric factors and anemia at booking. And from my own study, even though that those who were primary gravid were more predisposed to having anemia as compared to those who were multi-gravid, but there was no statistical significance with these. However, in some other studies that were carried out in some parts of the South-South and in the North, like a study that was carried out in Kano, showed that the primary gravid were more predisposed to having anemia, and that can be explained by their susceptibility to malaria hyperparasitemia. This is also a table showing the relationship between other factors and anemia, such as the genotype of the participants. And from this table, we can see that those who had genotype AA were more predisposed to having anemia when compared to those who had genotype AS. And we have, from the literature, we know that AS, those who have genotype AS is said to be protective against malaria also. So the p-value is put at 0.03. Again, on this table, we can see that those who had received hematinics prior to their first antenatal visits were less likely to be anemic from the table that we can see, while those who did not receive were more predisposed to having anemia. And that gave us a p-value of 0.00. From the study, we can conclude that we have found that the prevalence of anemia cooking in an environment is still very high. And the summary of the facts that we're gotten from our study is that anemia is more prevalent among those with lower level of education, subjects with monthly salary of 100,000 and less, those with genotype AA, those who had not used any form of hematinics prior to presenting to the antenatal clinic for the first time. And so we can recommend that there is need for universal basic education for the girl child, women empowerment, and pre-pregnancy care for all our pregnant women. These are some of my references, and I want to thank you for listening.
We thank Dr. Ajoku very much for that presentation. We'll now move to Dr. Nkpe Abe, who will be presenting risk assessment and prophylaxis for venous thromboembolism in the Prepare Room in the Tertiary Hospital in Nigeria. Is Dr. Nkpe Abe there?
It will be taken by Dr. Roslyn Ihiagwa, and I saw her here just.
Okay. Is Dr. Ihiagwa there then?
Now.
Yes, I'm here.
Dr. Ihiagwa, can you please, please unmute yourself and go ahead, please. Can you share your slides?
Yes, I'm trying to do that.
Are you having challenges?
I've tried to do so. I don't know if it's visible.
No, it isn't. Dr. Additional, can you help us out? Yeah, one.
Dr. Yaga, did you send the slides as requested? Because you see, we still checked yesterday night. I'm not sure we saw your slides.
I did mean.
What?
Yeah.
Sorry?
Or does she have this?
I did this morning.
Dr. Yagba,
I did send it this morning.
You asked you to send it yesterday to prevent this kind of whatever. Well, it's okay. Let me quickly look for it. Okay, it looks as if you started sharing. Okay.
Is it visible?
Well,
Coming up,
black screen.
Okay, can you do something? Can you take down your slides, please? I've been able to locate your slides so that we don't lose the time that we've gained.
Okay, I've done that.
Okay. Let me see. Okay. I think you can see the slides now.
Yes, ma. Okay.
I think you should start, please. Your time has started counting.
Okay. Good morning, professors, consultant, my colleague. I'm Dr. Ihe Agwam. I'll be taking the presentation on risk assessment and thromboprophylaxis for venous thromboembolism in the puerperum in a tertiary health facility in Nigeria. The authors are as shown on the slide. Next slide. Venous thromboembolism is a leading cause of maternal morbidity and mortality in the puerperum. Relative risk is increased in pregnancy and further increase in the puerperum. The absolute risk is low. Overall incidence in pregnancy and puerperum is 1 to 2 per 1,000 pregnancy. It peaks in the first 3 weeks postpartum. However, careful assessment of pre-existing, new onset, transient risk factors, and employing optimum thromboprophylaxis can prevent VTE. The study was a retrospective cross-sectional study carried out at the University of Port Harcourt Teaching Hospital. Data was extracted from 212 hospital notes of inpatient postpartum women from January 2019 to January 2020. The demographic characteristics, risk factor for VTE, thromboprophylaxis, diagnosis and treatment of VTE were assessed. Women with VTE events in the preceding 4 months before pregnancy were excluded from the study. Data was analyzed using the PPS software. The aim of the study was to evaluate the practice of risk assessment, thromboprophylaxis, and to determine those who would have needed thromboprophylaxis. The demographic characteristics of the study population were analyzed, and among what was found, the risk factors that were found in these women, such as maternal age, accounted for 36.7% of the study population. Parity greater than 3 accounted for 48.11% of the study population. Other risk factors were found as demographic characteristics of the patient. Using the RCOG guideline, the frequency of individual risk factors were assessed. There was no patient that was found to be in the high-risk group. In the intermediate category, we found out that cesarean section in labor accounted for 15.57% of the study population, obesity, and alarming also was the 96.3% frequency seen in the population due to readmission or prolonged admission. Those that had 2 or more risk factor or intermediate risk factor as intermediate risk factor or less than 2 risk factor accounting for low risk factor were also assessed. And of note is the age greater than 35 years that accounted for, that was seen in 32.08% of the study population. We also had cesarean section being in 24.06% of the study population. And those that had preterm delivery were 24.35% of the study population. Prolonged pregnancy and postpartum hemorrhage also accounted for a significant number. We did a risk scoring of the patient's risk factor for VTE and the need for thromboprophylaxis in the study population. We found out that 90.09% of the study population had a risk score of between 4 to 10, and they were in the high risk category. Hence, they needed to have low molecular weight heparin for 6 weeks postpartum. However, this was not given. Generally, we also found out that 99.60% of the study population needed to be considered for low molecular weight heparin, but this was not done. Venous thromboembolism presentation or clinical features were assessed in these patients, and we found out that some patients presented with pain in the calf, redness of the leg, tachycardia, tachypnea, chest pain. There was no diagnosis of venous thromboembolism that was made. Of striking note in this finding was that 17 of the patients that had a score of 8, 13 of them had no sign, 1 had tachycardia, 1 had pain in the calf, and 1 patient had chest pain, leg pain, sudden death, and 1 had tachypnea. Of all these, no diagnosis of venous thromboembolism was made. In our overall assessment, we found out that of those that had risk factor, 23.58% of these patients had features suggestive of VTE. In conclusion, the study showed that irrespective of the morbidity and mortality that VTE could cause, assessment for its risks and prophylaxis was not a routine practice at the tertiary center at the time of the study. The prevalence of risk factor was high in the study, as high as 99.069% of the study population. This was significant, although it was higher than what is seen in the developed world and also in the multi-center study that was carried out in Lagos and South Africa. There was no case of VTE that was recorded in the study population, though there was a case of unexplained sudden death. We therefore recommend that a national guideline be written, that the Unified National Guideline on Thromboembolic Risk Assessment and Prophylaxis be written, taking into consideration the Nigerian disease pattern, cultural diversity, level of economic development, and peculiarities of the maternal care.
Dr. Hiagwam, you should be rounding up time.
That a prospective study be carried out and the created guidelines should be a benchmark for comparison. We also these are references. Thank you.
We thank Dr. Hiagwam for that presentation. Is Dr. Adeoti around now? Dr. Gestational, can you check?
I still don't see Dr. Adeoti. So maybe we'll just address the questions. I think that's the last for this set. So maybe we'll just address the questions.
Can you help us with the questions?
Okay.
to save time.
Yeah, just a minute. Let me look through.
Well, I think they are obvious here.
Okay, you want to go ahead, Professor Loyede?
Yes, we have a series of questions from those who had listened attentively this morning. I will just quickly go through them. The first one is to Dr. Ogunkwade. We stated that about 49% of the sickle cell patients booked late for antenatal. Are they previously booked in another facility? Are they booked in another facility? That's the question for you. Dr. Ogunkwade, please. Dr. Ogunkwade, please. Okay, we take the one for Dr. Abu Breeze.
Hello, can you hear me, sir?
Okay, please go ahead.
Yes, sir. Those ones were booked within the facility. They were those that were booked within our facility. Yes, sir.
Okay. So they were not probably booked in any other facility. That's the question.
Majority of them were not. Some of them actually came from other facilities. And once they come before, at least before the 3rd trimester, and then they come for more antenatal visits, we take them as the booked patients.
Okay.
Yes, sir.
Okay.
Thank you, sir.
For Dr. Abu Breeze, you used the IADSG criteria to diagnose GDM in your study. Why not the NICE? And could this have influenced your results? That's one of the questions for you.
Hello, sir.
Yes, please.
Good morning once again. Yes, I use the IDPSG criteria because it is similar to the World Health Organization 2013 criteria, which we adopt in our facility. The only difference between the IDPSG criteria and the WHO 2013 criteria is that the WHO tried to differentiate between DM in pregnancy and true GDM with those criteria, whereas the IDPSG lumped everything together and gave a compact value. So the WHO 2013 criteria are in ranges, a particular range that is from if I can remember now, from fasting value between 92 to 153 fasting value between 92 milligrams per DL to 126 is defined as GDM. Whereas when you have a fasting value greater than 126, they will likely want to tend towards DM in pregnancy. Whereas when you have a 2-hour value between 153 to 199 milligrams per DL, it's GDM strictly. Whereas if you have a value greater than that, it is DM in pregnancy. Whereas the IDS-PGS criteria put everything together, a single value greater than 92 fasting, 1 hour greater than 180, and 4 hours greater than 153. So that's why I use that. Now for the NICE criteria 2013, their values are slightly, their fasting is slightly higher than the IDPSG criteria, and their 2 hours is slightly lower. So that will just significantly reduce the incidence if I used the NICE 2015 criteria. But
so you agree it could have reduced, it could have influenced the results. You agree with the okay.
Yes, sir.
Okay, fine. I think that should have been stated somewhere in your presentation. And then somebody wants to know too, Mustafa from Shagamu, why did you exclude pregnant women with multiple pregnancies?
Okay, thank you very much. Yeah, thank you very much, sir. Multiple pregnancy is a risk factor for gestational diabetes mellitus. So to try to rule out confounders, that's why they were ruled out. It was part of my exclusion criteria.
I think that was defined there. And this Mustafa also want to know why anemia in pregnancy was defined using a cutoff of 33 and not 30. It's right because the study was carried out in a developing country. Why did you choose 33 and not 30 in a study in a developing country? I guess that is for the anemia presentation. That is Ajoku.
Yes,
Dr.
sir.
Ajoku, please. Why did you use 33 and not 30? Because
yes,
the study
sir.
was carried out here.
Yes, sir. I used 33% because I needed to use a cutoff that was universal. even though we find out that women with 30%, PCV of 30% and about 30% can do fairly well, but that does not mean that they are not anemic. So I just wanted to use something that was more universal by WHO. Thank you.
Well, I guess Professor Falabi is on this panel, and she's so much interested in anemia. Would you want to pass on 2 comments on that, using 30 and not 33 in most of our studies? Professor Falabi, please, if you are here with us.
Did you call me?
Yes.
What did you say?
There is this issue of 33 and 30 for studies done here as cutoff for anemia. She just told us that she's used 33 because she wants to have. Hello, can you hear me?
Oh, okay. The issue of cutoff for anemia.
Yes.
Yes, I can hear you now. My internet is going in and out. Yeah.
Okay. Well, somebody wants to know why 33 and not 30 for studies done here in developing countries. She's responded very well to say, for uniformity, she would have 33. But can you just give 1 or 2 comments on that?
Yes, I would like to comment on that. Yes, so we've always been saying that 30% is what we use here, and it's 10 grams per DL and all that. But the thing is, you have to have data to back up our assertion. In those days, and this was very old data, on the days of Harrison, we said that it was 10 grams per DL was picked because it was found to correlate with optimum birth weights. Okay, but since then, a lot has changed. There's no recent data, and the more general data coming and declared by the WHO is that it should be 11 grams per DL and not 10 grams per DL. So until we generate our own large volume data that says that our correlates with of 10 correlates with optimal birth weight, and we, it doesn't have to be 11. We need to move. That's the thing. So 11 is what WHO says, and it is the 10 grams per DL that we used to espouse is from old data. It's possible that it's still current, but we have to update it. That's the issue. And if we're doing research, we have to follow the general a general consensus criterion in order to be generalizable. So that's my take on that. Thank you.
So, Dr. Ajoku, we would be so much interested in your next, at the next conference, you probably come up with comparing outcome in 30 versus 33. That's an assignment from the national president.
Sorry.
Thank you, sir.
President to you.
Excuse me, Prof. Good morning.
Yes. Morning, sir.
There is a lot of, there are many hands up on this issue, and I think it's very important.
Oh, okay.
Can you check that, please? Because my hand is up as well. Maybe
okay, sorry, okay, please go ahead.
I should quickly give my own. There are so many hands up. I think, personally, I don't believe there should be a difference between Caucasians and Africans in terms of PCV. We've all worked everywhere. There is no difference, really, If you see average class Nigerian, their PCV is well above 33. No, honestly. So it's not a racial kind of thing. So I think I support the idea of making our PCV 30, 33 here. Anybody who is below 33, 11 grams is anemic. So that we say is optimal weight, this and that, is just because they thought as at that time, during Dawson's time, any people, they can manage 33, 30 anyway. But I don't think we have any reason to do that now. I think I support 30. I mean 33, please. I don't know.
Thank you so much. Thank you so much, Prof. President, your hands is up.
Yes, thank you very much. I don't think I still need to say more because my president has said concisely what I have in mind. But that doesn't rule out the fact that if in the midst of what you are doing, if you want to sectionize the ones with 30%, you can analyze and make findings. But in a work that you want it to be universal, you need to use what is accepted everywhere. That's my own way of looking at it. So we don't need to keep going, keep keeping keep saying 30%. And again, we will appreciate that in terms of when these 30% group are really subjected to stress, how much stress can they withstand? So we still group them as anemic. Thank you very much.
Thank you so much for the contribution. So for us on this group, therefore, we still agree as a panel to still stick to 33 for obvious reasons. And until that team comes up or more robust studies are done, they begin to look at whether we need to go back to that 30 or not. So that's an assignment for Ajoku. We hope you're able to do that at the next conference. So we have some other questions from Bandokwa. Can we truly say that there was no case of VT when there was no evidence of any attempt to diagnose it in the records? Can we say there was no case of VT when there was no evidence to diagnose it from the presentation you did? That is for I think, represented here by Senior History.
Okay. Thank you, sir, for the question. That question is very important. That is the essence of this study, because it appears like we don't have the VTE as a factor, as a condition that can lead to maternal mortality. So we don't recognize it, we cannot diagnose it, even when we have all the risk factors present. Facilities to do this diagnosis are not available, and the risk assessment is not, the health caregiver are not well trained on the risk assessment. So that's the essence of this research, so that we are aware and work towards making more diagnoses and treating the patients where they need be.
Thank you so much. From Professor Afolabi, was prophylaxis given in any of the high-risk patients in your study, in your center?
No patient received thromboprophylaxis because the diagnosis.
No, okay.
Yes.
The same question from Ehiagwan wanted to know if prophylaxis was given. I think that is about all the questions in the chat box. But let me just quickly, before the chairman of this session takes over, also show interest in the presentation from Dr. Abo Briggs that talked about mid-neck circumference and screening for GDM. Well, it will be interesting to know how you measured your mid-neck circumference, the protocol for it. If you want to reproduce it elsewhere, what should you be doing precisely? Because this study will not have been complete without that. And then secondly, can you correlate that mid-neck circumference with the glucose evaluation or screen that you did? Is there any correlation that if the circumference is this, then your or is there any of the study researchers that can come in there? And the reason why I'm bringing that up is because GDM or diabetes is another major issue we should be discussing every time we meet. And if you are therefore getting a screening tool for it, we probably want to encourage those who are bringing it up to be able to guide us as accurately as possible what we should be doing, to screen for it and reduce the burden. Dr. Abubrix, okay, I think we've lost. So in the absence of that, therefore, I want to hand over to the chairman of this session. So please continue. Chairman, please.
Hello, can you hear me?
Okay. Oh,
can you hear me?
Yes, I
I
can
think
hear you.
we've had a very exciting morning with all this presentation. My quick question is to Dr. Adekunle at Adeoyo Maternity Teaching Hospital. You are so close to the University College Hospital. So what was responsible for the disparity between your cesarean section rates of 5% and UCH, 7.5% and UCH 22%? Seeing as now you are a maternity teaching hospital.
Thank you, ma'am. University College Hospital is a referral center, even for Ade Maternity Teaching Hospital. Aside that, it's also a referral center for many other secondary healthcare centers within Ibadan, outside Ibadan. So that may be that may account for higher rates in Ade Maternity Teaching Hospital. More so, patients in Ade Maternity Teaching Hospital are usually they're mostly traders, and they tend to decline cesarean sections when they are offered. Many of them discharge given medical advice on account of cesarean section. So that may some of the reasons that because this disparity.
Okay, thank you very much. So in the absence of any more questions, I would like to thank the presenters and the participants, as well as the organizers. We've had a very interesting session, and we will conclude at this point to enable us to move on to the next segment. Thank you all. Thank you.
Thank you so much, Professor Anguze, Professor Oloyede. We've had, again, a very interesting and stimulating session, despite it being so early. We thank the presenters who shared their work with us, and we also thank all the contributors who contributed questions and made the discussion a very lively one. I can see Professor Gadosi is here already. The next session, the next 2 hours or so, is actually a workshop where he's going to be taking us through the growth chart and also introduce us to how we can introduce and implement it in our practice and in the country. Professor Gadosi, you're welcome, sir. For this session, Professor Tuko and let me see, and Dr. Awole. I don't know if Dr. Awole is here. I'm not sure I've seen Professor Tuko. Will be chairing. Okay. But Dr. Awole, maybe you can start. Professor Kuti can welcome Professor Gadosi, and we'll take it from here, please.
Hey, everybody. Hello.
Good morning, sir. We can hear you, sir.
We haven't seen Professor Gadosi on the screen.
He's here.
Okay. Hello, Jason. Good morning.
Good morning.
Good morning. We are delighted to have you back. Actually, you raised our hope yesterday, and everybody is here with itching ears to listen to the source. So you are welcome to teach us all this, and I think we find ourselves very lucky to have you on ground. Thank you very much. Please, you can start the book.
Well, thank you. It is my pleasure, and it is. I'm very pleased that there is so much interest. I would like to say from the outset that a workshop is interactive, or that's how I would like to do it. So I would be relying on you to contribute and hopefully maybe also answer some questions in the sense of how you think GAP could fit into the Nigerian system and into your practice. Maybe we could sort of, in the first instance, I would show you some more detail of our teachings relating to GAP and our experiences. But after that, let's say for the first hour or so, and then maybe have a very short break. And then in the second hour, if we go on for that long, I would suggest that there should be an interactive discussion the feasibility and the potential hurdles and so on of implementation. And that's where Femi, I would be also looking to you to give us a summary of your experiences so far, because this is something that you have been trying to work towards for some time. And we do need, collaboration. So maybe in the first instance, can I first ask you, while I've got you, is what is the current practice of fetal growth surveillance in the third trimester? And in particular, I'm interested to know whether there is a practice of one-off scans. I mentioned that yesterday. Or what is the current nucleus of fetal growth surveillance, or would you say that it is very varied depending on where you are?
Is that an open question?
Well, of course, you've got your own practice, but in general, in terms of what is, for example, are there scans done routinely at a particular gestational age, as often it is the case in countries in Europe, for example, but not in the National Health Service?
Yes, I would say that the practice varies from hospital to hospital. There is no national protocol, as it were, and this depends on how much people know about fetal growth and fetal monitoring. So in Nigeria, in our center, what of course, we acquired a lot of what the Prenatal Institute is doing in Ife. So we want one or two people to let us know. What we do in Ife is that we may scan, scan is done at booking. It's a routine thing at booking. And we try to do a few more scans all through the pregnancy. Initially, we were doing the one-off third trimester scan, but I think we then follow it up if there is any reason, and we manage high risk different from low risk in our center. So, but I want some of my other colleagues to let us know.
Yes, maybe the question to you is not fair, because you've already we've already had
yes, we've had a lot of discussion. Yes, so please.
and you in fact have been attending our workshops here in
Yes,
Birmingham.
I have. Yes, yes.
Everybody is still remembering Professor Kuti, and it was great to have you, of course. Yes, please, could others please chime in and give us an idea of what, not just perhaps their own practice, but what they see the practice to be in different parts of the country. And I'm particularly interested in not the discussion about dating pregnancy and assessing anomalies and so on, but third trimester fetal growth screening. This would help me to sort of also which way to that I know, and I can perhaps respond to what current practice is. And please don't all speak all at once. That's what I say in a live workshop, because everybody's muted, of course. So who would like to give an initial idea?
Yes.
Bosede Afolabi. I work in Lagos. I'm a professor of obs and gynae. In my practice, we scan most women are booking as well, but we do not have a protocol to scan everyone in the third trimester for growth. We're all over the place. I've been trying to set up a protocol for many different things. And I have done during my time as the chair, but in terms of growth, I have to admit that I haven't come to convince my colleagues to ensure that we do the proper thing. So, but it's all over the place for now. We're not doing anything detailed.
Can I ask maybe for one or two other contributions?
Thank you. Thank you very much, sir. Professor to Calabar. I know that looking at the country as it were, there are some centers who have their own protocols on how to follow. But if we look at it nationally, I would say majority of our centers in the country do what I may describe as scanning on indications. If you have a reason, most of them may scan at booking and subsequently will be on indications. Meaning, looking at the country as a whole, maybe some centers, depending on the knowledge and the facilities available. And again, when we look at the country as we are talking about, ultrasound, though it's becoming very common now in the country, is not owned by every center in the country. So I would say that universally, that's country-wise, we want to say that it is an indication. But tertiary centers where people have the know-how, they can have their reasons to do the scan at booking and subsequently probably anomaly scan and so on. So I would say indication is the main thing for Nigeria for now.
And so for indication in the third trimester, would that include suspicion of fetal growth problems? And if so, how would that be picked up? What is the primary way of assessing whether the baby is growing well or not? Or is that not currently very much in practice?
Well, I think like I said earlier, it depends on the center in question. Yes. Where we have people who have knowledge of ultrasound, what they can look for, they do it the way you are telling us now. But in some centers, they may not even actually go that far. So I still know that in some centers, people scan just to find out what is happening. If they suspect any anomaly, any disparity in terms of growth, they can send the forms or whatever to radiologists where they don't have obstetricians and still look for certain anomalies.
And on what basis would there be a suspicion of fetal growth problems? Is there such a thing as examining by hands or measuring the fundal height, or is that not in practice?
Most of the times is the use of fundal height, where there is disparity, that creates the suspicion in most centers.
Okay, but how do you define disparity, please?
Well, usually we look at, when we measure using a tape measure, we say the normal is within plus or minus 2 centimeters of whatever we obtain in the tape measure.
How many centimeters from the gestational age?
2 centimeters.
Plus or minus 2 centimeters.
2 centimeters higher, okay. 2 centimeters lower.
Great, thank you. Is that also sort of like the general current practice in other parts? Would others agree? Plus or minus 2 centimeters for a first step, or plus or minus 3 centimeters? I think nice guidelines headed here in this country.
Yes.
Yeah, it can get up to 3 in the third trimester. So more or less plus or minus 2 to 3, okay. Basically. Yeah.
Okay. Right. And as far as you know, there is no general practice of just, as I said, in many countries in Europe, to do a routine scan at 32 or 36 weeks or whatever. That's not the case.
I do that privately, but I don't think it's a routine thing for, general.
Okay. The reason why I'm mentioning that is it's a particularly, it is something that some clinicians here think they can do as a shortcut, as a reassurance. And I wanted to dispel that as something that not only hasn't got any evidence, but also it can lead to false reassurance. And I will show you a case to start with, a clinical case. We collect cases from mothers who sadly had a bereavement and want to know more information. I mentioned yesterday about the unexplained stillbirths, but there's also regrettably cases where the management just was not based on evidence, and so they're asking us to try to find some reasons of what has happened and so on. And regrettably, we are learning from such catastrophes, really, and wrong protocols that have been implemented. That's in this country. I can only report to you from experiences here and in other countries where we are working. I mentioned yesterday that we're active in several others, and we know what the practice is, and it is quite varied as you go around different parts of the world, but also in different parts of, even in the UK, although we have tried to standardize it, and we have standardized it in 3/4 of the trust. Another 25% are doing their own thing, maybe their own research or whatever, so it's not 100%, but the 75% of our hospitals that are following the GAP guidance, we know, and I think I showed it yesterday, that they are achieving a significant improvement in terms of reduction of stillbirth rates. May I ask you one more final question, which is about stillbirths? And excuse me for putting it very simply, is the prevention of stillbirths, is stillbirth rates on the agenda in Nigeria? And is there, in general terms rather than individual? I know Professor Kuti has been, as I showed yesterday, raising this for some time, but in terms of the government or in terms of the health service or whatever, is this something, is there awareness of the need to reduce, or is there even statistics that show that it is going down or staying the same or whatever? Could anybody give me some idea of whether there is an awareness of the need to reduce stillbirths in Nigeria today?
Well, can I quickly just respond to that? The practice here now is at such a level where stillbirth reduction awareness is not top on the priority list. So we can't therefore say there is, real attention to that, beyond what we do generally. But then, like you rightly pointed out, individuals have that consciousness, and they are doing it at one level or the other. But as a rule, generally, we have not. It doesn't seem to be that prevalent.
Well, you have started by putting fetal growth as a subtitle of your conference this year, and I congratulate you in that regard. But of course, then the question is, do you feel that there is, how would you then address this issue, or is it in comparison to other priorities, not one that is for which its time has come as yet, do you feel?
Before the national president talks, AFEMSON president talks, I think, in my own view, we started addressing it with this kind of discussion. Because after this, I'm sure the consciousness, awareness will increase tremendously. And we start discussing what should we be doing, beyond what we are discussing here, to be able to reduce stillbirth rates in Nigeria. And individuals will now be coming up with what they've been doing, evidence-based.
Okay.
Right?
So, okay. Well, I think that this is helpful. Is there anybody else who would like to add anything regarding to that? Because I need to know into which environment I'm giving presentation, the last thing I want is to talk about things that are not relevant. And I'm very conscious that in terms of standardizing this part of the assessment, it's early days. And Dr. Abby has got her hand up. Please go ahead.
Hello?
Yes?
Yeah, are you hearing me?
Yes?
Yes, as mentioned by Professor Oloyode, things have been done on individual level. For instance, in Rivers State, in Port Harcourt, we have an understanding with the Primary Healthcare Management Board of Rivers State, whereby the intention is to reduce maternal and prenatal mortality. In the first place, we have identified the causes of seabirth and the causes of maternal death. Two of those causes is preterm birth and preeclampsia. So we put forward a mechanism whereby screening would take place in Rivers State. The screening is not on the level of tertiary, it's not the level of tertiary institution, but on the level of primary health care. This goes to the community. The communities will be sensitized and will be screened for preterm birth by doing cervical length and doing screening for preeclampsia by doing uterine artery Doppler and maternal and obstetric history. So we are on that now, and we hope we achieve results.
Excellent. So I think that's a very important area. In terms of numbers, in terms of losses, I think I showed yesterday one of the reasons why we've been mostly focusing on fetal growth in the third trimester, and in particular late onset growth restriction after about 32 weeks, is because the majority of stillbirths in our country are related to that. And where we also have dissimilarities, where it is different from, I suspect, in your as well as other countries in Africa, Asia, is that there is a higher proportion of intrapartum deaths, whereas in our service, it tends to be around about 10% of stillbirths are intrapartum. I think it's more closely to 50-50 or whatever in many countries, in lower middle income countries. I'm not sure whether that is correct for Nigeria. Please correct me. But our focus on antepartum stillbirths has been, and my talk or anything that we teach focuses in on that, because that has been the close to half of our stillbirths relate to fetal growth restriction, placental problems, and clinically not picked up, and their late onset growth restriction. But I acknowledge that there is also early onset growth restriction, as well as preeclampsia and premature delivery in general, and of course also intrapartum related deaths. So I just want to define that our area relates specifically to the surveillance of fetal growth restriction, of fetal growth in the third trimester, and in particular in the late third trimester, because that's where we have a lot of deaths. Dr. Abbey, please. Your hand is still up, I assume, for your comment.
Yes, that's right. I can add to it that in Rivers State also, we understand that more than 50% of perinatal mortality is intrapartum, due to intrapartum causes. And early neonatal death is also raised due to intrapartum complications. And that is why we are also introducing CTG, electronic fetal monitoring, in labor. At least we are doing admission CTG to pick up those cases of chronic hypoxia that we need cesarean section straight away. As you rightly put it, we are also trying to screen for gestational age right there in the first and the second trimester using the Fetal Medicine Foundation London protocols, where I did some training in fetal medicine. The intention is to pick up these small babies and see how we can follow them up as early as possible in pregnancy. But regarding the 10 small babies, we are not screening them well because we don't have protocol on how to do growth scan in Nigeria. People use different parameters to do growth scan, and we'll be working on that to get out protocols that will answer those questions.
So do you feel that there would be interest if we proposed a straightforward, easy to implement and locally appropriate protocol? Would there be a wide interest to sort of see whether that could be implemented based on the available evidence, but also, I repeat, appropriate to your circumstances and resources and so on? Because I believe that an organization such as yours could be the champions to establish something like this countrywide and implement something that is specifically suitable for Nigeria, including customized charts based on your population rather than imported from somewhere else. So that really is my question.
Well, I agree with you. That would be very appropriate, so that we are able to do things that we are able to get things that we can implement easily in the general population. So
Yes, of course. The topography of Nigerian diversity may be associated. It will go a long way reducing.
Okay. And I'm not sure who, Femi, you had your hand up as well?
The number of babies that die, and I think it will all go well with the economy. I'm through.
Yes, yes, I have my hands up. I'm sorry, I think I have to chip in one or two things at this stage. There is certainly real need for Nigeria to have the stillbirth rate reduced. We probably have the highest now all over the place. And as we have seen, a lot of people just do their own thing. There is no strict awareness. The younger ones are interested in cottage technologies, but there is a simple thing that midwives can implement that can be utilized across the country. And that is why we have used this opportunity to introduce all our colleagues to fetal growth restriction, monitoring of fetal growth across board by simple technology. It's simple. That's what has fascinated me in this. And it has made a lot of changes all over the world. And so I think will be very highly welcomed in Nigeria by most colleagues. And I think is the way to go, honestly.
Okay. Well, this has been helpful for me. And if that's okay, maybe I should proceed and showing you some basic principles of what we teach in them. Maybe we can go back to a more general discussion of how you feel that would sort of fit in. Are there any other comments before I start showing some slides? Dr. Awowole, I've got a hand up still.
Yes, thank you, Prof. Just to give a response to your question, which has been answered, but since you acknowledge me now, one of the researches that we presented yesterday confirmed that what we do currently, which is to use cervicofundal to monitor fetal growth, only 21% of the babies that were thought to be small by cervicofundal actually had IUGR. And by implication, we went on to do many cesarean sections that would probably not have been indicated if we had had other appropriate means of monitoring. But we were only able to use this application because we were doing umbilical artery Dopplers, which many centers can still not do yet. So it will be very helpful if we can have an appropriate low technology option, which can go across all centers, and only those who are identified by that could then go on to be doing the Dopplers, which are more expensive, required expertise, and not readily available. Thank you for recognizing me.
Well, thank you. I think that's that would lead us nicely into some of the things I want to talk about. Can I just please ask you, Dr. Awowole, how do you define IUGR? Is it when you said not recognized or recognized, but the babies were not IUGR? How do you then define that based on birth weight, and what standards do you use? Dr. Awowole, you're still muted. Are you able to answer that, or shall we come back to that later, maybe? That's fine. So let me, oh, yes, please go ahead. Yeah, because that is quite essential, what standards we are using, and I'm about to talk about the different standards and so on. When you say that it is falsely recognized growth restriction, the babies were the fundal height measurement was small, but the baby was not IUGR, and so the unnecessary intervention, I think, is essentially really very important as well to recognize. Did you want to, would you be able to elaborate on that just briefly? What standards are being used in your practice at present to define that somebody is IUGR? Okay, maybe we'll come back to that later. That might be maybe a technical problem. Sorry, please go ahead.
Oh, so I was just answering your question that we defined fetal growth restriction as estimated fetal weight less than the 10th centile using the Headlock 4 growth chart, okay, with umbilical artery pulsatility index greater than 95th centile.
Okay, all right, let's understand it. And finally, can I ask, when you say based on fundal height, how do you assess that the fundal height, according to fundal height, it was small? Do you use a chart, or is it what we said before, a plus or minus 2 or 3 centimeters of gestational age?
So what is universally acceptable is in our center is to use fundal height with up to 3 centimeters below what we expect for that gestational age. Okay. However, perinatal unit, because I work directly with Professor Kuti, so in the perinatal unit, we have the growth chart, which we use with our own mean estimated weight of 3.2 at birth for a term baby.
Okay.
So to further use charts in our unit.
Okay, great. Thank you very much. That's been very helpful. It helps me to sort of, you know, how to target what I'm saying. So I will now just very briefly, first of all, deal with the one-off scans, and then also with fundal height, and I can focus on that, as well as risk assessment, because all of that is part and parcel of the thing. So allow me for a moment to now just start to share my screen. And I just need to sort of get rid of that, and we'll go for so yes, you can see this, okay? I hope you are.
Yes, we can see it, Prof.
Yes, we can.
So in terms of the summary of the strategy that from picking up from yesterday was that the requirement already mentioned this morning, the importance of increased awareness. Most stillbirths are not unexplained. We have to understand the causes, and we did that by case reviews, looking forensically into the case notes of these sad events, and we found that most of them were potentially avoidable. To understand the risks, we studied large databases and found that fatal growth restriction was the strongest single factor. Recognize and manage low and high risk from the beginning of pregnancy. I already mentioned that there needs to be focus on recognizing, even within the community, which mothers need increased surveillance through serial assessment or by scan. Excuse me. We need the appropriate tools, and then we need to monitor as well and have evidence-based protocols and guidelines. And these were the sort of summary points from yesterday. Most notably, normally formed stillbirths are associated with growth restriction. And this is, of course, mostly antepartum stillbirths. However, I must say that intrapartum, there are also many of the babies that get into trouble during labor have got diminished reserve and have been unrecognized antenatally that they were growth restricted. So growth restricted babies get into CTG problems more quickly and become acidotic more quickly. They've got diminished reserve. Most IUGRs late onset are currently not recognized. Adequate surveillance requires serial assessment of girth, customized charts, improved detection of SG and IUGR, implementation, training, and audit increase antenatal detection. We've shown that. We've established that on a large scale. We produce about 600,000 growth charts in the UK each year. Improved detection results in a reduction of avoidable stillbirths, and I've shown evidence of that yesterday as well. I just wanted to give you deal with the one issue, which is it's tempting for us clinicians to say that is there a magic bullet to sort of detect these babies that are not growing? So let's do a scan at 32 or whatever weeks. And many countries do that in Europe. And I just want to discourage you from going down that route. So here is a mother who had the stillbirth, is communicating with us about this sad outcome, trying to find reasons and explanations. She had a scan at 34 weeks. So so that was her routine third trimester growth scan. It showed 2,100 grams. It also had all the measurements were sort of recorded on the machine, including the individual parameters. They were even plotted there for you. Everything was fine and within normal. Used the Headlock formula. For good measure, don't ask me why, because it was within normal limits. She also had Doppler, and I think we all agree that the evidence is that the Doppler in normal sized pregnancies has not been established to have any use, but she's had that anyway, and that was normal as well. So we produced a customized chart for her because she came from a non-gap unit. We knew her not pre-pregnancy, but early pregnancy weight and height. She had also normal BMI. So we plotted it on the customized chart, and this is where she was, and that was reassuring. Then she said she didn't have but she was monitored with fundal height measurements all the way through. We don't have the fundal height measurements, but she said towards the end of my pregnancy, the last few weeks, I complained to the midwife a few times that my bump didn't feel very big. And she said, I was just in the recommended measurements, so wasn't worried. I think the midwife was doing the plus or minus 2 or 3 centimeters, which to our shame, the National Institute of Clinical Excellence has been recommending until not long ago. So I wasn't worried. So it seems strange to me that I'm a tall woman and not petite. I think I must have always been in the lowest buffer. But her own experience about the bump didn't feel very big was also an important observation. Always listen to the mother. Wasn't worried. So then, regrettably, sadly, she had a stillbirth and it was 2,640 grams. So if you plot that, then you can see that this baby was yet another IUGR stillbirth. And I'm sorry, I think somebody has got their microphone on and is producing some unwanted noises. Thank you.
Dr. Akpan, please, can you turn off your mic and video? Dr. Ubong Akpan, please.
Thank you. So this was the date of the stillbirth, 13.5 days. And you can see that there has been very little growth since the first measurement. And we actually have that because she had this as a routine scan. And the only thing that this scan did was to give her and her care provider false reassurance that everything was fine. Did not rely on the serial measurement, which we don't have, of fundal height, which would have shown that if done properly by trained staff, that this was slowing down and requires further investigation, scan, Doppler, before the baby dies, and of course, timely delivery. And so it just became yet another statistic. I showed this graph, I think, before to show that how many babies have not fulfilled their growth potential. This is the plot of stillbirths in our environment when we first started. So so that's one thing. I just wanted to now switch over. If you just give me 1 second, and I want to talk about fundal height measurements. I'm going in between different things, so just bear with me for a moment. What is really important by the way, these are some slides from our electronic training as well. The principles, standardized technique, and some summary points. They are the primary surveillance tool to assess fetal growth during pregnancy. The procedure is acceptable to women and easy to perform. Historically, there has been insufficient emphasis on teaching and training a standardized method. As a result, a variety of different methods have been applied, including the use of anatomical landmines, calipers, without midline correction of the upper uterine pole. Not surprising, there is a substantial inter-observer variation by the same person at different times, as well as inter-observer variation between different observers. For the same reason, the evidence of the effectiveness of fundal height assessment is varied and led to many severe misconceptions. The proposed rule that I already heard this morning, and it's still in practice in some areas in the UK and elsewhere, is that weeks gestation should equal fundal height in centimeters. It's absolutely false, because the normal range varies with gestational age and with maternal characteristics. So just imagine if you've got, if you accept plus or minus 3 centimeters, let's say, and you've got a measurement of, let's say, 30 centimeters at 32 weeks. And then the next time, no, let's say 34 centimeters at 32 weeks. And then the next time is measured at 34, 35 weeks. It is also 32 centimeters, and it hasn't grown at all, but it's still within the limits of your rules of plus or minus 3 centimeters. The other thing is that the term symphysis of fundal height is a misnomer, as the measurement should start from the variable point, the uterine fundus, and lead to the fixed point, not the reverse. However, SFH is commonly used, abbreviated as SFH, and because we can't get rid of that abbreviation, we're going to call it standardized fundal height measurement. Starting from the top, we'll leave both hands free to first palpate the uterus and find the fundus, and hold one of the measuring tape. And you have to measure rather than just, with one hand and leading the tape with a free hand to the fixed point, the term simple. Once you've got that, that's very easy. You just go down until you hit something hard, which is a symphysis. And the main emphasis is to standardize the procedure. Now, the procedure includes the bladder needs to be empty. If full, it can falsely add 2 centimeters to the measurement. It's firm, flat surface, mother semi-recumbent, and non-elastic tape with centimeter scale hidden, so that you don't sort of say, oh, right, you're 32 weeks, we expect it to be around about 30. Oh, look at that, I'm very good at this. It was around about 32. No, you need to try to make an independent assessment and then to see, and then to plot it. So here's the mother made comfortable and semi-recumbent. You palpate the uterus with both hands and determine the fundus. Hold end of tape at fundus and run down longitudinal axis with centimeter scale hidden, and measure to the top of the symphysis, and then record and plot on the chart. Additional points is to measure the same standard technique throughout pregnancy. Do not allow adjust for descent of the head. Do not allow. We just heard yesterday in our national meeting, one of the case reviews, where they, it's like normalized their observations to sort of say, oh, all right, it was down, but the baby, the centimeter was less than expected, the measurement, but the baby's head was coming on. That is, you're not measuring that, you're measuring the height of the fundus. So, and normal fundal height growth does not flatten that term. Otherwise, the charts, the fundal height charts would be flattened that term, but they're not. They do continue until delivery. An uncompromised baby is expected to continue growing until birth. And just to re-emphasize that SFH measurements are not meant to predict fetal weight. Their main value is to assess the growth rate, the slope of the curve, and compare it with the growth curves. This is the main reason for seeking to reduce inter-observer error by standardized measurement, and inter-observer error for all care providers trained to the same standard. Measurements should be carried out 2 to 3 weekly, as part and parcel of seeing the mother to see whether everything else is okay, whether that's affordable within your service. It is sometimes difficult even in ours, but the midwives are the lead carers, and they're trained, and that's what they do. And they have about 9 visits all the way through. Up to delivery and plotted on the chart, each measurement should be done once. In other words, not need to repeat and take averages of 3 measurements, just once. And if a referral for scan is required on the basis of fundal height measurement, another clinician should not remeasure, as it may lead to false reassurance. You cannot do fundal height measurements in the case of high BMI, and we set it at 35, but even 30 tends to be more difficult. There's just too many layers in between the abdomen and the fundus, multiple and large uterine fibroids. We have difficulty to define that, but maybe more than 3 or 5 fibroids, and if they're substantial in size, of course, then that doesn't, it makes it difficult. Polyhydramnios and multiple pregnancy. Now, for mothers receiving serial scans, SFH measurements are not required and not advised, that they may add confusion to the interpretation. So that's fundal height measurement basics, and that's essentially can be done remotely, but better, obviously, in sort of like train-the-trainer type of situations. Now, let me just show you how they're being plotted, because they need to be plotted on charts. But before then, I think I really ought to give you some basic evidence about the customized charts and how they are the basic principles, because I didn't go into that yesterday. Much of what I'm saying, by the way, has got papers that you can download from our website, and a general overview of rational validation and clinical benefits from the American Journal of Obs and Gynae. And this is one of ultrasound, fetal growth surveillance, current guidelines, practices, and challenges. And this one is a comparison of customized versus intergrowth I'm sure you have heard about the intergrowth standards, which claim that one size can fit all patients, mothers, babies globally, which we, I think, have had shown for some time. It does not represent evidence, and many other papers are showing that intergrowth standards do not fit for their own population. These papers, as well as others, are on our GAP page, and you're welcome to download them. So customized charts, I think I already mentioned, they calculate based on the mother's details the term optimal weight. The weight at 40 weeks that should be expected to be reached in that particular pregnancy, adjusted for maternal height, weight, ethnic group, and parity. And it was different for this mother versus that mother, because of not just ethnicity, but maternal size. And that is then sort of entered into the GROW app, which has a third, where you can choose whether you want a 5th and 95th, or we also have the 3rd and 97th Centaur. You plot his fundal height measurement by X and estimated fetal weight by a circle or a dot. And if you sort of do a fundal height measurement here of, let's say, 29 centimeters at 32 weeks, for this particular mother, that is too small, and for this mother, it is fine. So this is where it leads to unnecessary intervention if you use the wrong charts. If you use a chart, if you plot a measurement like this on this chart, if you produce a chart like this for this mother, then you will end up with a falsely low fundal height measurement, which may lead to unnecessary intervention. And if you use a plus or minus 2 or 3 centimeter standard, as you use for in some areas still in the UK or elsewhere for babies that are perhaps expected to be of different size, then you will miss a lot of cases and or intervene unnecessarily in lots of cases. So frontal height measurement, just like ultrasound scans, need to be plotted on the right standard. Rather than just one measurement, it's important also to do serial assessments so that you can do the velocity, the slope of the curve. In fact, frontal height measurements are particularly suited for that rather than the individual measurement, because the individual measurement can be well outside because the mother's stature or whatever, it's not useful for estimating fetal weight, but especially taken by the same clinician, midwife or doctor, it gives you the idea whether or not it follows the expected growth velocity. Not necessarily within it, but that slope is really very important. Here, of course, it is not and should require referral for ultrasound scan. Even if it is like this, without it being small for gestational age here, but that we teach should initiate a referral for ultrasound scan to reassure, and ideally 2 ultrasound scans, but there were many units here also are struggling with that. But at least 1 scan to see whether or not at least the baby is normal size. And of course that can be plotted on the same chart, weight based on scan, frontal height, because there is a relationship within that based on some studies where we incorporated that into the software. So a measurement, let's say here, of 3 kilograms, that's 3,000 grams at 40 weeks, is reassuring for this mother and absolutely not reassuring for this mother. And she obviously would, at 40 weeks, I think most people would suggest to her that she needs to be delivered. If it's a bit earlier, then of course, Doppler investigations and at term, in particular Dopplers like middle cerebral artery, rather than relying on umbilical artery. So that's where the customized chart comes in, that it adjusts for the individual maternal characteristics. This is individually adjusted, it's optimized, excluding pathology. So we're basing the standard is based on the assumption that this is going to be an absolutely normal pregnancy, against which we can then assess whether or not there has been a slowing of growth. And it is based on a fetal weight curve rather than a birth weight standard, because of course there's an association between prematurity and growth restriction, and you cannot use preterm birth weights as a standard for fetal growth. So we're using a Headlock-based proportionality curve to combine the term optimal weight with that curve, and so therefore it shows for each individual term optimal weight what the growth curve should be. And it's adjusted for maternal height, weight in early pregnancy, ethnic group, and parity. And of course, with ethnic group, that's where we require, and we can discuss that later, where we need to derive a Nigerian standard or more than one Nigerian standard based on different parts of the population and ethnic groups. And we are very happy to do that. And we are optimizing the standard. So if we've got a database, then we exclude, of course, anomalies, smoking and diabetes and other such factors, because we want to produce the term optimal weight. That's why it's called GROW, gestation-related optimal weight. That's the standard. So that so for example, it's not to predict, let's say a mother smokes, and if you include the coefficient to predict what her term optimal weight is, you might be better in predicting that she's going to have a deficit of, let's say, I don't know, 100 grams, because if she smokes. But we want to not predict what the actual weight will be. We want to predict what the optimal weight will be as if she did not smoke, so that we better recognize that the growth has been affected by smoking. In fact, in terms of adding variables to the birth weight prediction, the more you add parity, ethnicity, maternal height, maternal weight, you are better at able to predict what the weight should be within the normal range. So there are lots of studies that show that customizing is better in terms of predicting outcome. I don't want to go into depth, but the papers that I showed you that were online, I will summarize that quite clearly. If you wanted to compare a population-based standard such as Headlock or intergrowth with customized, you can sort of see, well, how does it apply to different mothers based on outcomes in terms of which ones better predict adverse outcomes. So if we look at different size mothers that are within normal BMI and have normal outcome pregnancy, they have different charts because of different maternal size. But let's take out BMI. So they're the same BMI, but they're still of different size. So they will have different growth charts. So the small mother and the large mother. And if I was to ask you, how does smallness or large different size affect perinatal mortality? Well, if everything else being equal and no pathology and no other factors varying between small and large, they've got the same risk factors or not, then in fact the perinatal mortality should be the same for small mothers and large mothers. And that's in fact is the case in our population. Now, in terms of the SGA rate, if you say that, what is the SGA rate? Well, if you customize for maternal height and weight, then the SGA rate will also be the same because you've adjusted for it. And it will represent the maternal, it will reflect well the perinatal mortality rate during these, in this spectrum. But if you use a population-based standard, for example, the Headlock standard for growth or other SG population standards, then you have an excess of apparent SGA for the small mother, where you've got the smallish baby, which is fine for her, but on a population-based standard, it shows that it's got a high SGA rate. And you've got a, for the big mothers, it suggests that in fact the baby, the SGA rate is small because you're just using one standard to fit them all. Whereas if you customize, then you can recognize better that this baby for this large mother is perhaps not growing well. So that's the effect that for any population-based standard is overestimates for small mothers and underestimates SGA for large mothers. And that's the same when we looked at different databases. This one is a Dutch database, and this one is the one from the WHO and the intergrowth standards. And we looked at this in 1.2 million births. So you've got the customized standard that reflects very well in this case, it was stillbirths, not just perinatal deaths. It reflects well the stillbirth rate across the spectrum of maternal size. And SGA rate reflects it well, whereas intergrowth is well below and has a similar curve as the WHO one size fits all, which means that the small mothers have got a higher rate of SGA, which does not reflect the perinatal or the stillbirth rate. And there have been sort of different papers. I don't want to go into sort of intergrowth too much, but they're essentially showing that using SG by the intergrowth standard will result in an excess of cases which are not related to stillbirth, whereas SG by the gestation-related optimal weight, the customer standard, identify additional cases here which have got significantly increased risk of babies dying. 65% additional cases with significant risk was not recognized by the intergrowth standard. So the intergrowth standard were these were the additional ones. And this is an independent study from New Zealand. And there were other studies also showing that intergrowth does not work in that population. And my senior statistician, Andre Francis, looked at 10 different countries, 1.2 million births, and compared grow versus intergrowth, and found that the similar thing that SGA by grow only identified additional cases that were at increased risk, whereas SGA by intergrowth did not, as you can see. And then the ethnic origin, I don't want to spend too much time on it, but there is a lot of papers there. The intergrowth, for example, they were sort of from 10 different countries. I circled Kenya, there weren't any other African standards, but you can see that there is a variation between different countries, which in fact contradicts their claim that one size can fit all. Now, if you have, even in our population, if you have different subgroups of the population with a different average birth weight, and you cut the same SG cutoff of 10% for one population, the European one being 10%, you can see that it increases many more of the other ethnic subgroups. And that means that many of the babies that are suggested to be even like a 200-gram difference here between these, then you see that a large proportion of SGA is actually misclassified. So it's quite important to try to adjust the SGA assessment to the population that you are looking at, and hence the customer standard. Now, maybe I'll just pause there if there's any questions about that, but what I could also do briefly is to then show you how the Centaur Calculator works. So let me just, can you see the Centaur Calculator here? Yes, you should be able to.
Yes, we can see it.
You can or cannot?
We can see it. Yes, we can.
Thank you. So we've got a Centaur calculator. If you just have sort of one measure that you want to sort of check or whatever, you don't have a growth chart, then you sort of say, let's say, put in the maternal height, the weight at booking, and then we do have quite a few coefficients now, over 110, but not a very good one for Nigeria. But for now, we do have one, which, let me just start with, let's say, United Kingdom, and let's say England. I'll come back to the other one. And parity, let's say, just keep it simple, was a first pregnancy, and then we'll put in a gestation age of, let's say, 36 weeks, and so live birth, we can also calculate for stillbirth by deducting an average of 2 days, which is the usual average delay. It's not, of course, always the case. And let's say this was a male, and the birth weight was, let's say, 2,800 grams. And it calculates the Centaur. Oops, I'm sorry. it calculates the centile, and it is quite okay. So let's edit, and let's call it like at 36 weeks, it would be 2,500 grams, and we calculated it with 40, and we're going to sort of gradually come down to sort of say that, okay, what is SG at 36 weeks? I'm going to edit again, and oops, and let's say we got 2,000 grams, and calculate that, and you see that this is a small baby. Let's give it maybe a little bit more, let's say 2,300. Now, I still want to sort of get a little bit closer to an SG baby. So, now, if you change the parameters, and this is a small mother in England, etc., and you can change the parameters and try it for different. So, for example, in Eastern Europe, tend to have larger babies. I don't know, let's say we have Poland. And you calculate again, you can see this is even smaller baby. They sort of adjust the centile according to where they are. Now, our coefficients for Nigeria is derived from elsewhere. It is not very reliable. Well, let's say we go to West Africa, and we've got Nigeria here, and we calculate the same. It is higher, and if I took a for example 2,200 and calculated, that would be within normal limits, whereas if I sort of did it for a different country, so it's imprecise if you're not specific to the country. We need to get more data to be able to do a customized chart for Nigeria, and that's something we can discuss in a moment. The other thing we have is just a quick demonstration of the customized chart itself, and let's say who's born then, ethnic origin. So we've got all these ethnicities, and so if she's a British European with one parity, height, weights, and it calculates the BMI for us. The EDD can be entered if it's known, and if it's not known, it will calculate it for you. So let's say she's due tomorrow, and generate the chart. Oops, page is timed out. Okay. No, I don't know why it is not working at first. Maybe it's because I'm streaming or whatever. So in any case,
the expected date of delivery should be beyond. You put 10th of July there. Maybe that's why.
What was the question? Sorry.
No, you put 10th of July as the expected date of delivery. We're already beyond 10th of July. Could that have affected it?
No, but it does allow it does allow late deliveries. I think it's the actual application is currently not working. I'll come back to that maybe later. I'll see what is going on. I won't spend time on that now, but I think what we could do now is maybe just stop for some questions let me just see whether I can stop sharing for a moment. And because I covered quite a few bits and pieces, so please let me have some comments. While you're thinking about that, I'll maybe I can just briefly show you one more thing here, which will also show you the not just the different fundal height standards, but something that we looked at in terms of our own population and the appropriateness of the fetal, in this case, the Headlock growth curve for different parts of our own population. So here's a chart which is adjusted for a mother who is European, height, weight, etc. And she's got a 2.5 kilogram estimated fetal weight at 37 weeks. And this is where it plots for her. Whereas for, if it's a ladies from Pakistan, and this is her height and weight and so on, that same weight and that same gestation is absolutely within the normal limits. Now the question is whether if we readjust these smaller babies on this chart, whether or not we're missing cases that are still at increased risk because of this weight, and we've sort of shown it to be because we moved the chart down for her characteristics, whether that represents an increased risk of the baby dying. And so 56% in this population are actually not SGA if you adjust these apparent SGA ones for European mothers, if you adjusted the chart for Pakistani. So in fact, if you do that, that is the case in 56% of cases. And the perinatal mortality rate of these readjusted cases is not different from one. In other words, they're the same. So that's what this shows in the sense of these are truly false positive assessments. And so to reliably do fetal growth surveillance prospectively, you cannot use a one chart fits all, because you will then intervene unnecessarily. And there are just sort of quite a few papers that show that these interventions are unnecessary. So before even introducing any standard within practices elsewhere, and of course in Nigeria, we need to make sure that we do not, that we use the right standard and do not increase false positives, unnecessary intervention. First, do no harm, of course. And so that's why I sort of wanted to emphasize that.
All right, Professor Gadosi, I want to thank you very much for your wonderful presentation. Now, I just want to ask a few questions. Now, on a general note, do we say that the fetal weight or the birth weight is determined by genetics or by the environment? That's one.
But
now, okay, good.
Let me deal with that. Of course, it is both, as we know, but there is a significant element of genetics, which some of it which we can predict, and some which we can't. So when we are adjusting for maternal characteristics, by the way, paternal characteristics are also important, but much less so. So we tend to not adjust for them. But if we had the father there and we were able to measure his height and weight, then there would be a slight improvement also in the prediction. But it gets complicated for various reasons. And some of it, of course, relates to the father not being there at the clinic to be measured. And jokingly, I also say, well, maybe the father wasn't even there at the time of conception, if it was somebody else. But of course, that is a comment about our population and relating maybe to paternity. But no, that's not why we do not adjust. Of course, we adjust for the mother because that's her characteristics are the main influence on growth. But even within that adjustment, there will be, of course, a lot of variation, and that's things we cannot adjust for or predict, of course. Environment is important in terms of, I guess, mostly pathological factors. In the extreme malnutrition, of course, but other aspects of pathology, for example, the environment of the air or the nutrition, smoking I mentioned, diabetes, and other such factors. So our prediction is for assessing or producing a chart based on everything being absolutely normal, the supernormal prediction, against which then you can measure whether or not the baby's growth is following that, and to better predict and identify if it doesn't. Socioeconomic aspects, of course, are also very, very important. But when we produce charts for different ethnicities, countries, and so on, we always just go by the absolutely normal pregnancies with no complications, so that we produce the optimal standard against which then locally the clinicians can measure growth based on their measurements, but also based on their assessment of the other risk factors of the mother. So risk assessment is very important. And I can add a few slides to go through the importance of risk assessment and the algorithm to follow in high risk versus low risk pregnancy. That's maybe something that we can sort of go back to in after some questions.
All right, thank you very much. Now, just two further questions. I remember yesterday we talked about implementation science. So now I'm looking at implementation in a country like Nigeria of the customized growth charts. One of my fears is because most of cost of care here is out of pocket. Will this not increase the cost of care? That's one. Then two, I see that it is hinged a lot on good and reliable ultrasound service. So to an extent too, that may have a challenge in an environment where, again, the cost of care is there, and then the reliability of the ultrasound measurements to assess the gestational age of babies.
Yes, and you're asking now questions which ultimately go back to the more generic question, the overall question, whether or not there is a will or appetite or even ability, resource to address the issue of avoidable stillbirth associated with antenatal growth restriction. And you're absolutely right. The question is, do we want to? Do we have the resource? And but at the same time, you are identifying issues which are related to that need to also be considered. So if you're relying on, for example, fundal height measurement to identify which babies are or are not growing well and need to be sent to ultrasound, then absolutely the staff need to be trained rather than as at present in your country, as well as many other places, people do not trust it because they're not using a standard which is appropriate, and also to train them to do it serially, to look at growth rather than size, and so on and so on. Then the second point is, if they are then being referred for further investigation and ultrasound, that then the scan service needs to also be up to scratch. It needs to be led by a quality assured service and clinicians who are well trained. Otherwise, of course, again, you increase the intervention without improving the outcome. These things go alongside of it. And the question is then whether or not it is more at risk in the current situation to include it. The only thing that I wanted to add to that is that if you are wanting to reduce preventable stillbirths, then having a system, a protocol, and training tends to actually reduce unnecessary intervention. As we already heard, there, plotting on current charts and so on is something that is can lead to unnecessary intervention. And so I would suggest that you can reduce adverse outcome and unnecessary intervention by better trained staff.
Thank you very much. I think Professor Kuti raised his hand. So Professor Kuti, sir, you can make your comments. And then after that, Dr. Abe.
Well, thank you very much for that question, Dr. Nabudozo. I want to let you know that it cannot increase cost because most Nigerians are now interested in scan. Many of them scan. And although they scan in the wrong places, if you look at the average woman, even a market woman that is of low socioeconomic class, once she's pregnant, she rushes to somewhere to go and scan. So that's number one. So scan is not really, people scan. But what we need to encourage them to do is to book early. But the good news really is that for the high-risk patients that we are talking about in this, for using this gap to monitor and all the rest, these high-risk patients usually come to the teaching hospitals. They want their pregnancy to succeed, and many of them do register early, even in our setup here. And the thing is for us practitioners to know that this kind of cheap service is available, and that we can then need to educate our people to book early and take important data like the data we first sent to Perinatal Institute. It was about 5 years ago or something. I can't remember. Maybe Jason will remember. It was rejected. It was rejected because there are a lot of missing data. So now at the end of this meeting, I think we know some important things we have to get record of so that we can really have a growth chart for different parts of the country. Once we have this, then the charts are available. We all do sinusoidal height measurement. In fact, it will reduce cost because from the paper we only presented, there is low, the intervention is less. And if you don't follow through very well, there is unnecessary intervention. Thank you.
Thank you very much. Dr. Abe.
I want to ask a question and a suggestion. The question is, how acceptable is customized growth chart to ultrasound companies? That's the question. Then the suggestion, if it's acceptable, we know that ultrasound companies give avenue to measure for biometry. And after measurement, we use different charts. So if customized growth chart is acceptable to all, is it not good in order to reduce costs to propose to them to factor customized growth charts in their software so that instead of using the cheat chart or the Headlock chart or any other chart, we use the customized growth chart as we scan. And that gives us information from the machine, and that will automatically reduce costs.
We have approached the ultrasound companies, and although they are now starting to get an interest incorporating, they need to establish a link, a so-called API, application programming interface, to link into our software. And so it's not very, very straightforward. They can easily incorporate a standard which is a one-size-fits-all, but to incorporate one that is individually adjustable is more involved, and they haven't prioritized it. If you can convince your ultrasound companies that are active in Nigeria, I will be very happy to work with them and to establish a link between our online software and their application. That has been done several times with the major information system, maternity information system providers in the UK already, and they are producing charts within their system linked to our server. So it works with information system providers, so it should also work with ultrasound providers, but they have not as yet, that's why after several years, prioritized it, because I do not know why. So if you can convince them, we'll be very happy to work with them. But please remember also that the customized chart has got two axes, the fundal height as well as the fetal weight. It focuses on estimated fetal weight only. Individual parameters such as BPD, abdominal circumference, and so on are not customizable, because we use the customization on the basis of the birth weight. So we're collecting large databases of birth weight on normal pregnancies, and then we connect that up with a proportionality curve, and that's what gives you the chart that I've displayed on the system. And so the birth weight can be customized based on the the variation of the mother, but ultrasound-based charts tend to be one size fits all rather than individually adjusted. So we are relying on EFW only, and that can be customized. Individual parameters cannot. So there's also perhaps because of that a limited desire by ultrasound companies to incorporate it into their system. It needs to be online, it needs to be linked with our servers, and it's not as straightforward as you might think. And I absolutely agree with your premise that maybe that would make things easier, but in practice it has not been the case.
Thank you very much.
All right, thank you, Prof. There's a question here. It says, using the gap, what is the average expected increase in estimated weight with each assessment?
It depends on the interval of the assessment.
Yeah, I know.
So on average, maybe I can dig this out in a moment. On average, you would have about 25 grams per day. And if it's less than 20, we've done this work some time ago. If it's less than 20 grams per day, then that is associated with increased risk of adverse outcome. However, that is in a European population. So in different populations, the slope or the velocity, or therefore you say the weight gain, is different. It depends on the individual mother's characteristics, ethnicity, her size, and so on. But roughly, approximately, it is the expected in our population is around about 170, 180 grams per week. And if it's less than that, then you know. So one of the issues about growth velocity, which we're doing a fair bit of work on right now, is of course to recognize it in relevance to the two measurements that you've done to actually establish the slope. I could give you a whole different lecture on growth velocity, but in basic terms, that's what it refers to.
At this stage, before we proceed, I'd just like to recognize Professor Toko. He has actually been with us here. He is also supposed to chair the session with Dr. Awoli. Professor Toko, you're welcome. Thank you so much for joining us.
Thank you. Good morning, and my sincere apology for joining late. I had a misconception about the chairing, but I'm happy to be here. Thank you so much.
Please go ahead, Professor.
Okay.
And proceed.